And hello to our viewing audience. Welcome to the Center for Constitutional Studies at Utah Valley University in Orem, Utah. I'm Scott Paul. I serve here in the center as interim director and as executive director. We are thrilled that you are joining us for this conference examining American federalism through the lens of the COVID-19 pandemic. As we begin this session, I need to express on behalf of our center, our gratitude to the Utah State Legislature, and especially to the legislature's Utah Federalism Commission for their enduring commitment to functional federalism and for their support of our Federalism Index project. We also thank UVU Provost Dr. Wayne Vaught and UVU President Dr. Astrid Tuminez for their support of our center. Moderating our panel today will be Troy Smith, a professor of politics at Brigham Young University, Hawaii. I'll turn the time over to Troy to introduce you to our panel.
Thank you, Scott. Welcome everyone to this panel, Federalism, Liberty, and Public Health, which is part of the conference Federalism on Trial, Lessons from COVID-19, sponsored by the Center for Constitutional Studies at Utah Valley University. Thank you to the university, the Utah State Legislature Federalism Commission, and the Center for supporting the study and understanding of the U.S. Constitution, and in particular, federalism. A particular thank you to the many people at the Center for Constitutional Studies who've made this possible: Scott, Andy, Kari, Jamie, and so many others. My name is Troy Smith. I'm a professor of political science at Brigham Young University at Hawaii, and a big supporter of the Center and its efforts to improve constitutional literacy. We're pleased to have you join us for this panel. The panel is addressing the difficult question of how federalism fosters and inhibits both liberty and public health. To help us understand this topic, we have a panel of excellent scholars. The format of the panel is we will proceed in the order of speakers as listed in the program. I'll introduce each in turn. There will be time for question and answer at the end of the presentations. You can submit your questions via the chat on YouTube or email them to constitution@uvu.edu. Our first speaker is Keith Whittington. He's the William Nelson Cromwell Professor of Politics in the Department of Politics at Princeton University. He's published widely on American constitutional theory and development, federalism, judicial politics, and the presidency. Somewhere in the background over here, I've got a couple of his books. He's the recipient of multiple awards for his scholarly work, including the Thomas M. Cooley Book Prize, the PROSE Award for Best Book in Education, the Heterodox Academy Award for Exceptional Scholarship, the C. Herman Pritchett Award for Best Book in Law and Courts, and the J. David Greenstone Award for the Best Book in Politics and History. Quite a prolific scholar and doing excellent work. He'll be speaking on Does Public Health Now Exceed State Competence? Professor Whittington.
So thank you very much. I appreciate the invitation to be here. I'm sorry that we have to do all of this virtually under our current circumstances, but it's an important topic, and I'm glad the school and the center were able to assemble a group to talk about these important issues. I do want to focus my time on thinking about does public health now exceed state competence? I want to use this as a way of talking more generally about the structure of the American constitutional system and where public health has traditionally fit into that structure. And then think a little bit about whether or not the current pandemic raises questions about whether or not that existing set of constitutional assumptions still makes sense going forward. This is not the first time that we would have rethought some of the fundamentals of how the constitutional system works and potentially shift some power from state and local governments to the national government. And so I think it's an important question to be thinking through whether public health now is in that category of policy issues that we might imagine in the future is going to gradually be shifted to the national government and away from the states. It's no accident that when this particular pandemic started, states took the lead in responding to this public health crisis. And some of that may be a feature of this particular presidential administration and the ability and willingness of the administration to act in the face of this kind of public health crisis. But to some degree, this simply reflects the nature of the American constitutional system. All through American history, states have been understood to have the primary responsibility for addressing public health. Often they do that in much more routine ways, not necessarily in the context of a public health crisis, but nonetheless, states broadly have the primary responsibility for dealing with public health. And when that involves epidemics or even pandemics, it's the states that are most positioned to most directly respond to this. The reason for this is because what's known as police powers are part of the background of the drafting of the US Constitution in the first place and are fundamental to the structure of American constitutionalism more generally. The police powers and the concept of police powers is really inherited from the British common law system. It was assumed that the state governments possessed the police powers, which generally speaking was understood to be the power to regulate, to protect the health, safety, morals, and welfare of the community. So very broadly open-ended sets of powers that states were simply assumed to have to be exercised by the state legislatures to act in the name of public health, as well as a variety of other kinds of issues. Now, this came at the state level with a variety of implicit and explicit limits. There were explicit limits on the police power that were imposed by specific constitutional requirements and specific constitutional rights that were guaranteed to individuals against the ability of state legislatures to impose regulations on them. Most of those constitutional rights came out of state constitutional texts. Some of them are written into the federal constitutional text as well. Moreover, courts increasingly recognized that there were some implicit limits to this general public police power capacity to respond to public health, as well as other kinds of ills facing society. In particular, courts emphasized through much of the 19th century a notion that state legislatures were armed with police power in order to advance the public good, the common good of the community as a whole, but it would be a perversion of that power to advance the interest of particular individuals or particular groups at the expense of the common good. And so courts were sometimes willing to investigate to what degree particular state policies adopted by legislatures in fact seemed to be promoting the public health or whether they were really doing something else. Notably, there's no comparable general police power at the federal level. Instead, the design of the US Constitution is one of enumerated powers where Congress is not simply given an open-ended power to make regulations to protect the health, safety, morals, and welfare of the community, but instead Congress is given a set of very specific powers, an enumerated list of powers. And then the question for Congress when it wants to regulate is where, if anywhere, that particular power that it wants to exercise can be found within the list of the text provided for in the US Constitution. So that leads an overall structure for the American constitutional system in which the federal government's role is relatively limited to respond to a great deal of public policy issues that might interest us, whereas the states have a general well to draw upon in order to respond to specific kinds of issues. In the context of public health, that doesn't mean necessarily that the federal government has no role to engage in, to be involved in public health, but it means that role is going to be somewhat limited and it's going to be tied to other more explicit powers because there is no specific enumeration of powers in the US Constitution to empower Congress to act for the public health broadly. That's meant, though, traditionally the states have had the authority to adopt measures that might be necessary to protect against the spread of disease generally. And in particular, when there are extraordinary dangers, as is sometimes raised by public health crises and in the context of epidemics in particular, that can lead to very extraordinary state actions in response to those kinds of actions. This is a power that can grow to respond to the nature of the threat the states are facing. This is relatively unusual for us, but much more common through much of American history. Fortunately for us, we've had to deal with fewer public health crises. We deal with fewer epidemics. We deal with less of a problem of the spread of infectious diseases than was true for large swaths of American history. And so for much of our history, it would have been much more familiar to citizens to imagine the aggressive actions that state and local officials might take to respond to outbreaks of infectious diseases, for example. We've now gotten a taste of what that looks like, although our version of it is quite unusual in keeping with the unusual nature of this particular disease. But this nature of this power to respond to public health crises is itself a non-unusual one within the context of American history more generally. And we see states and local governments organizing themselves to provide officials to be able to respond to these all through American history. So for example, when what was then characterized as the village of Brooklyn was chartered initially, included within its very charter for that village was a power to create a public board of health that had the power in turn, in the case of the prevalence of any such pestilential or infectious disease in any part of the village, to enclose and shut up such infected part so as to prevent all intercourse therewith. Now, obviously, this is older language and less familiar to us, but the key move here is that in setting up localities, and Brooklyn certainly was not unusual in this regard, states routinely empowered them to make decisions that whenever there's an outbreak of infectious diseases, to close off those localities so that travelers would not interact with those localities, so that the disease would not spread beyond the borders of that particular locality whenever possible. The hope was to contain the spread of infectious diseases to a small area. And not only were state officials empowered to do that, but likewise local officials were as well. This could quite often be quite expansive as to what kinds of powers government officials could take in this regard. So New Hampshire, for example, authorized its local health officers to remove any person infected with the smallpox, the malignant cholera, or other malignant pestilential diseases to some suitable house, and to buy them provided for that purpose. That is, they could remove infectious people to a quarantine house, which many localities maintained in an era in which there were routine spread of infectious diseases. People would then be isolated in those quarantine houses. They would be monitored and cared for in those houses, but not permitted to leave until they were regarded as no longer infectious by government officials more generally. Moreover, New Hampshire, as was common in lots of other states, went beyond that and also specified that government health officials could make such regulations respecting such house and for preventing unnecessary communication with such persons as they may think proper, but also to make other kinds of regulations they may think necessary in order to prevent the spread of diseases. So there were expansive authority for state legislatures to act, but also a willingness of state legislatures to pass on that authority to other kinds of government officials. And we've seen that in the present crisis as well, where state legislatures have been less directly involved in responding to the current pandemic, and state governors and other executive branch officials at the state and local level have been much more involved, relying on this pre-existing legislative statutory authority that state legislatures have handed off to executive branch officials to make the specific decisions that might be necessary in the crisis. So this is quite wide-ranging. This is recognized all through American history. The Supreme Court recognized that this ability of states to respond to public health crises it could even lead to states infringing on what otherwise might be thought of as national political prerogative. So for example, states were recognized as having the authority to stop travelers at the borders of the state, to inspect them, to collect inspection fees from them, to turn them away if necessary, or even to isolate and quarantine them. Now, we might generally think that this is a violation of the authority of interstate commerce that Congress generally has the authority to regulate. But when it came to public health issues, states had an expansive authority to interfere with transportation and travel that might occur across the border. That included people, but also included things like disease livestock, for example, that might pass across state lines. And this has been familiar as well through American history, in which there was this concern of how do you prevent people from crossing state lines? How do you prevent diseased livestock and other animals from crossing state lines and carrying disease from one state to another? And states were understood to have an expansive authority to stop people and stop animals at the border in order to prevent the spread of disease beyond the border of the state, but also prevent the spread of disease into the borders of the state. And again, in this pandemic, we've seen gestures at this by some state governors who at least were threatening to try to shut down their borders and prevent the spread of people from states that were experiencing worse situations relative to the pandemic. Although no states went as far as states often did in the 19th century in actually quarantining people who were passing across state borders, turning away people at the state border, inspecting people at the state border to ensure that they were not going to carry infectious disease into the system. But we've experienced moments in American history as well where states seem so challenged by the kinds of governance issues that they were encountering that increasingly the federal government became involved, and judges over time began to understand that power needed to shift away from state and local officials to national political officials more generally, which raises questions about whether our current public health crises and the rise of pandemics in general will create a similar kind of influence and pressure within the modern constitutional system that we've seen at earlier points in American constitutional history. In the late 19th century and early 20th century, for example, a great deal of governance responsibility was shifted from the states to the national government. This was primarily in response to changes in the design of the economy and the nature of economic actors, with the rise of a national marketplace and the growth of large corporations that cross state boundaries. There was an increasing push toward a nationalized regulatory response. State competition in that context was seen as dysfunctional. You needed the ability to regulate the ability of corporations that could cross state boundaries easily, as a consequence, put states in competition with one another in ways that were seen as contrary to the public welfare more generally. National boundaries were seen as less permeable to capital flight, and so it'd be more possible to capture corporations and regulate them from the perspective of the national government than it would be from the perspective of the state government. All that created pressures for saying, okay, well, this kind of regulatory authority that increasingly was demanded needed to be done at the national level, even though traditionally it had been done at the state level. And of course, there's a lot of constitutional jurisprudence that suggested it was supposed to have been done at the state level. In addition to the early 20th century movements toward a more interventionist and more of a welfare state, increasingly call attention to the possibility that states simply had too limited capacity to provide the kinds of resources and benefits that the public was increasingly demanding. And again, that too shifted authority toward the national government, which was seen as having greater capacity to provide the kind of political response to the kinds of crises, the kinds of pressures that the public was demanding responses to. That was obviously the case in the context of the Great Depression, but we had experienced that well before the Great Depression as well, in which there was this increasing sense states simply didn't have the resources to do what was necessary to protect the public well-being. It's imaginable, at least, that persistent pandemics could likewise feed pressure for centralization. We might argue, for example, that there's a need for global coordination of official responses to a pandemic that's crossing national borders and not just state borders. And if there's a need for global coordination about how best to fight a pandemic, then we might think that that's best done at the point of the national government rather than being done by the state government. We'd rather have the president and the national members of the executive branch coordinating with other countries on how to respond to a pandemic than imagine that each governor is going to individually have to be attempting to coordinate a response with an international set of actors, whether international governmental agencies or other national governments more generally. Likewise, in the context of pandemics, we might worry that internal borders simply are too porous to simply have a local response. Just like we worried that corporations could move across borders and as a consequence escape regulation, and therefore we needed a national response that could capture those corporations and impose regulations on them. We might think that in the context of pandemic, when we're not talking about a relatively isolated geographic area that's suffering a particular outbreak of an infectious disease, but instead we're seeing disease spreading across international borders and then sweeping across the country as a whole, we might think that local responses are always going to be inadequate, and we need to be thinking more broadly about how best to respond to those kinds of pressures. It's one thing to try to shut down the borders of the village of Brooklyn or even of the state of Louisiana in the context of a particular infectious disease outbreak. It's quite another thing to imagine how we're going to monitor internal borders in a context of a pandemic such as the one that we're facing right now. And third, like in the early 20th century, we may think that there's a need for substantial economic resources to respond to the pressures of a pandemic that simply exceed what it is the states can do. We're certainly seeing in the current circumstances that the economic pressures created by the pandemic are quite substantial. The amount of money that is necessary in order to help support the economy and help support governmental responses in this current situation are quite substantial. States are not well positioned to muster the kinds of resources that the current pandemic is necessitating. If this is a one-off, then you can easily imagine, in fact, we return to a much more normal situation. We go back to an expectation that states are going to be taking the lead in dealing with public health moving forward, that the national government's response is going to continue to be relatively small and relatively limited and on the margins. On the other hand, if we start thinking pandemics of the sort that we're experiencing now are going to be a regular feature of our social life moving forward, then that's going to create pressures for the constitutional and political system to adjust in order to make us better positioned to be able to respond to those kinds of pandemics. And I think it'd be quite natural for us to conclude the states by themselves are not going to be the best actors to take the lead on those issues going forward, but instead we'd expect more of a coordinated national response to deal with pandemics if we're seeing a whole wave of them into the distant future. So thank you.
Thank you, Professor Whittington. Interesting dynamic element of the Constitution as a dynamic system rather than rigid and fixed in the way it's set up. Our next speaker is Ilya Somin. He's a professor of law at George Mason University. His research focuses on constitutional law, property law, and the study of popular political participation and its implications for constitutional democracy. He's the author of multiple books, including Democracy and Political Ignorance, Why Smaller Government is Smarter. His work has appeared in numerous scholarly journals and a variety of popular press outlets, including the Wall Street Journal, Los Angeles Times, CNN, USA Today, and others. He's also a regular contributor to the popular Volokh Conspiracy Law and Politics blog, which is now affiliated with Reason Magazine. The title of his presentation is Free to Move, Foot Voting, Migration, and Political Freedom. Professor Somin.
Thank you so much to the Center for Constitutional Studies for organizing this event and all of the other panelists for their insightful presentations. I'm going to be talking today about my recent book, Free to Move, Foot Voting, Migration, and Political Freedom, which talks about the importance of freedom of movement to political choice, both within federal systems like the US and also through international migration. Obviously, I had what may have been the bad luck of releasing a book on freedom of movement right around the time that many of us went into lockdown in many parts of the US and indeed throughout the world. My hope, however, is that that experience will get people to appreciate freedom of movement perhaps more than they did before. So in this presentation, I will give an overview of the thesis of my book as it relates to both federalism and also international migration. And at the end, I'll talk about some of the implications of my argument for the COVID crisis and how to handle the spread of disease more generally without sacrificing freedom of movement. Obviously, I finished the book before this crisis began, so there are only a few references to disease in the book, but I think the general framework that I present actually works well for this crisis as well. So I'm going to now share my screen if that works, and then you will be able to see the exciting PowerPoint presentation that I have for the book. As you can see, this is the cover, and the book came out from Oxford University Press just a few weeks ago. I should be able to move on to the presentation. So in the book, I deal with 3 types of foot voting. Foot voting under federalism, where you can choose which state or local government you want to live in, based in part at least on the public policies there. I also talk about foot voting in the private sector, as for example with private planned communities, and through international migration, which is the most controversial type. And at the end of the presentation, I'll talk about some possible objections to expanding foot voting, which include the fear that if we allow it to occur right now, then disease will spread. The COVID crisis perhaps will be even worse than it currently is. But first things first, why should we even think of foot voting as a mechanism of political choice? Most of us tend to think, well, the way we choose what government we want to live under is at the ballot box, like we're going to be doing for the rest of this month. Many of us choosing who will win the presidential election, for example, Trump or Biden, or who will gain control of Congress. I think it's definitely the case that ballot box voting has important value, and it does enable you to exercise a kind of political choice. But ballot box voting has 2 important limitations. First, in almost all cases, the chance that your vote at the ballot box will make a difference is infinitesimally small. In a presidential election like the one we're having right now, it's roughly about 1 in 60 million, the odds that your vote will be decisive. If you live in a swing state, it might be that it will be as high as 1 in 1 million or something like that, but it's still extremely low. And the same goes even for state elections or local elections. The odds may be higher, but they're still very low overall. In most contexts, we would not say that you have meaningful freedom of choice if you have only a 1 in 1 million or a 1 in 60 million chance of determining the outcome. We wouldn't say, for example, that you have meaningful freedom of religion if you have only a 1 in 1 million chance of being able to determine what faith you're allowed to practice. And I would say the same thing is true of ballot box voting or of political freedom, that a 1 in 1 million chance isn't actually very much political choice at all. Similarly, precisely because the odds of making a difference are so low, it turns out that voters also have very strong incentives to be ignorant about most of the issues they're voting on. That if your only reason to become an informed a voter, to know about politics and government policy, is to cast a better informed choice, the very low odds of being able to do that mean that that isn't much of an incentive at all. And as I describe in this book, and in greater detail in my previous book, Democracy and Political Ignorance, overwhelming data shows that in fact, most voters know very little about the issues that they vote on. So it turns out, therefore, that only about a third can even name the 3 branches of federal government: the executive, the legislative, and the judicial, and are often ignorant of other very basic information. The American Medical Association says that if a doctor is going to operate on you or treat you in any way, they first have to get your informed consent. Like medical treatment, government policy is very often literally a matter of life and death. We've all seen that during the COVID pandemic, but I think it's true to a large extent even in normal times. Yet in most cases, democratic government as it currently operates is like being treated by a doctor whose administrations you're not allowed to refuse, or you have only a 1 in 1 million chance of being able to refuse them. And also, most of the patients have very little idea of whether the treatment is actually effective or whether it's more likely to be snake oil. Foot voting has tremendous advantages under both of these dimensions. When you choose where to live in a federal system or through international migration, if you're allowed to do so, that choice has a high likelihood of actually making a difference. It's much, much higher than 1 in 1 million. Even if, say, your spouse or family members participate in a decision, still you may have 1 chance in 2 or 1 chance in 3 of making a decisive choice, which is way, way better than 1 in 60 million. Similarly, for that very reason, lots of evidence and also just common sense shows that foot voters acquire more relevant information than ballot box voters do. If you're like most people, you probably spent more time and effort the last time you decided what television set to buy than the last time you decided who to vote for president or for any other political office. That's not because the TV is more important than who sits in the White House or that it deals with more complicated issues than the federal government. It's because you know that when you choose a TV, that's the one that will actually end up in your living room, most likely. But when you flip on the TV and you have the misfortune to see the president or some other politician, the chance that you can affect who that is infinitesimally small. So you probably devote less time and effort to considering information about that decision. In the book, I also tie in these two advantages to several different theories of political freedom advanced by a wide range of political philosophers and theorists, both left and right, libertarian and conservative, also left-wing. So this is not a distinctively libertarian perspective or a distinctive, unusual perspective of some other kind. It's one that I think holds true under a wide variety of assumptions of what counts as political freedom. And I'm happy to talk about that further in the questions. For now, I'd like to take a closer look at the specific types of foot voting. The most familiar one, I think, is foot voting under federalism, where people can choose between different states and local governments. And in the US, that means at its best, you have a very wide range of options. 50 state governments, almost 90,000 different localities. That's a wider range of options than certainly you get in almost any ballot box voting election. And you stand much better chance of finding a jurisdiction that actually fits your preferences and works well for your needs. Historically, as I discuss in the book, it is actually the poor and disadvantaged that have benefited the most from this kind of foot voting, people fleeing racial and ethnic and other kinds of oppression, people seeking opportunity to get out of poverty, and so forth. In the book, I explain how this kind of foot voting under federalism can be beneficial even if local and state governments are not actively competing for residents, even if there's just a diversity of policy that exists for totally extraneous or even random reasons. But obviously, things are heightened if the system actually does incentivize states and localities to compete for residents. And I discuss a number of ways that we can create incentives for such competition and thereby empower foot voters even more. There are a number of obstacles to effective foot voting, such as moving costs, and in recent years, things like restrictive zoning and occupational licensing, which make it especially difficult for some of the poor and lower middle class. I discuss various reforms that can be used to mitigate that, and also how decentralization of power to lower levels of government can actually reduce moving costs. It's cheaper to move from one city to another than one state to another, for example. The next kind of foot voting that I'd like to look at is one that is less familiar. It's foot voting in the private sector. Many people don't even think of this as foot voting at all. Nonetheless, currently in the US, we have almost 70 million people who live in private planned communities like condominiums, homeowners associations, and so on. And often they provide many of the same types of services as state and local governments do, including security services, educational services, environmental amenities, and so forth. And this has important advantages even over foot voting under federalism. In a given area, we can fit many more private planned communities than state or local governments. So this increases the range of choice. In addition, a lot of social science evidence suggests that the quality of services provided by private planned communities is often actually better than that provided by state and local governments. There's better incentives to provide good services and more competition in this particular market. The fact that 70 million people already take advantage of this, I think, severely undercuts the standard criticism that this is only available to the wealthy or that this is just the rich walling themselves off from the rest of society. We don't have 70 million super wealthy people in the United States, I think, but I do recognize this form of organization, at least currently, is less available to the poor and disadvantaged than to others. And I suggest some ways in my book to make it more available and more feasible for more people. I don't claim, by the way, that Private planned communities can completely displace state or local governments or federal government, or for that matter, that states and localities can completely displace the federal government. As Keith mentioned in his excellent presentation, I think there are going to be scenarios and some issues that only the federal government can handle, or perhaps that only can be handled at an international level. But there are many ways to decentralize power to both the state and local and the private level to facilitate greater foot voting, even if we can't hope to decentralize absolutely everything. I also discuss in the book a number of possible other types of private sector foot voting, such as private school choice and allowing private providers of services to compete with public ones to a greater extent. This can also provide more foot voting opportunities for more people, including the poor and disadvantaged. The type of foot voting that I think is the most controversial, but also has the greatest possible gains, is foot voting through international migration. And here the gains are so enormous because the differences between jurisdictions here are so much larger than they are domestically. If you think of whatever you believe is the best governed American state and compare it to whatever you think is the worst, it's probably a substantial difference, but it's nowhere near as great as the difference in the cases that are up on the screen right now. You have refugees fleeing the totalitarian communist state of Cuba right away upon entering the US. There's an enormous contrast in terms of their liberty on all possible dimensions. Similarly, Syrian refugees fleeing to the US before Donald Trump virtually shut down nearly all refugee admissions. These people also are fleeing a very oppressive regime, as well as terrorist groups such as ISIS, and people escaping from repressive governments, ethnic and racial minorities fleeing persecution, women fleeing patriarchal societies, and so on. They experience enormous increases in both freedom and economic well-being almost as soon as they enter a relatively freer and wealthier society. And the gains here are hard to completely measure, but they're enormous. They're bigger than almost any other gains of a similar type that we can conceive of through any other policy change. I would add that for the 1/3 of the world's population that lives under authoritarian regimes, foot voting through international migration is virtually the only possible way that they can hope to exercise any political choice of any kind. They don't even have the very limited political freedom that we Americans have through ballot box voting. It's also worth noting that the gains here are not just in terms of freedom, but also there are enormous economic gains. Economists estimate that if we had free migration throughout the world, we would double world GDP. That is, the world would be roughly twice as wealthy as it is now. The reason for that is that there are so many millions of people currently trapped in locations where the government is so oppressive or so corrupt or so badly flawed in other ways that no matter how smart those people are or how hardworking, they have little or no chance of escaping poverty. But when they cross into the US or Western Europe or Japan or another similar, more advanced society, they almost immediately can be 2 or 3 times more productive. And that doesn't even count the enormous gains that might occur over time through improving their skills, where the opportunities for that are also likely to be greater in the destination country than in their home country. Now, despite these enormous gains, there are obviously lots of objections to free international migration and also to empowering internal foot voters as well, though the objections are usually made in the international area. In the book, I divide the objections into 2 categories. One is objections where it is claimed that governments had a categorical right to exclude, that they don't necessarily have a good reason. Have to have a good reason, they can exclude almost any time they want. The second category, and this includes the COVID crisis, is situations where it is said maybe there isn't a categorical right to exclude, but we got to exclude people because otherwise specific types of public policy problems would be caused. The spread of disease, overburdening of the welfare state, spreading crime, and so forth. I'll talk first briefly about the general right to exclude. And in many places, the most common version of this argument is that a particular area really belongs to people of a given ethnic or racial group, like on the screen right now. France is for the French, and you could also say Germany is for the Germans, Italy is for the Italians, and so on. This argument doesn't work that well for the US because if anyone has the right to exclude in this country under this theory, it might be the Native Americans. So perhaps they have the right to get rid of all the rest of us. But even on its own terms, this argument has many problems that I go through in the book. The biggest is that if you take it seriously, it's a license for racial and ethnic discrimination. In a domestic sphere, we readily recognize that either racial and ethnic discrimination should be banned, or at least there should be a strong presumption against it. So we readily condemn something like South African apartheid or racial segregation in the US, where governments force people of a particular racial or ethnic group to live apart from others. But this argument essentially replicates the same idea on the international level, but the same objections also apply. As in the domestic sphere, you're essentially classifying people based on their ancestry and ethnicity, something they don't control, and something which is a morally arbitrary factor, which says nothing about how good a person they are or how much freedom they should have. And you're also imposing severe restrictions on people's freedom on this basis, essentially because they committed the crime of choosing the wrong parents. Whether it be French parents versus some other kind of parents, or Anglo parents versus Hispanic parents, and so forth. The type of objection that is more often made to justify a categorical right to exclude in this country is, and the analogy between a nation and the owner of a private house or members of a private club. So it is said, if I own a house, I can exclude strangers for any reason I want. I don't necessarily have to have a good reason. Similarly, if I organize a club, I can again organize on any basis that I want. I can have my club of my fellow Red Sox fans and exclude fans of other baseball teams, or even just people who just don't like baseball at all. It's hard to say that baseball fans are necessarily better people than, say, football fans, but I can exclude on that basis nonetheless anyway. There are many problems with this analogy, and I go through them in some detail in the book. Here, I'll just mention perhaps the single biggest one. If you take it seriously, it has dire implications, not just for immigrants, but also for natives. Consider that the owner of a private house has the right to restrict speech in that house. They can say only pro-Republican speech will be allowed, or only Democratic speech. Similarly, they can restrict religion. I can say only my preferred religion will be practiced in this house, only Christianity or only Islam, and much the same thing can be said of a private club. You can have a Republican club or a Democratic club or a Christian club or a Muslim club, and so forth. So if the government's powers really are analogous to those of a private homeowner or those of members of a private club, then it would follow they can suppress speech and religion as they wish, and also impose all sorts of other restrictions on people that would be very severe, perhaps even rising to the level of totalitarianism. So I think there's good reason to reject these kinds of analogies, even though they're common in public debate. And I have even been advanced by some distinguished political theorists, but I think they're still wrong. More weighty is the argument that says we must restrict migration rights in order to prevent various kinds of specific public policy problems. I mentioned the coronavirus crisis and the spread of disease. There's also the fear that migration will overburden the welfare state, or that it will spread crime, or that immigrant voters will come in and vote in a bad government that adopts harmful government policies, and so forth. I don't claim that we can definitively reject all such arguments in all conceivable circumstances, but I do think they're not nearly as powerful as they often might seem. And I develop a general framework for addressing them, a three-step process. First, we should ask, how big is the problem to begin with? Very often the answer is it's not actually that significant. For example, all the available evidence suggests that increased migration does not overburden the welfare state. To the contrary, most migrants are net fiscal assets. But let's say that there is a real problem, and I admit there sometimes could be, then I would raise the possibility we should ask whether there's a keyhole solution. That is a way to address the problem that is relatively a way to address the problem without actually excluding migrants. And there are many examples of this. For instance, if migrants are overburdening the welfare state, then you can simply restrict their eligibility for welfare, as we already do. Finally, we can tap some of the enormous wealth created by migration to address possible negative side effects that keyhole solutions won't fix. For instance, if you worry that native labor is disadvantaged by migrant labor, then you can simply use some of that wealth to subsidize the wages of the relevant native workers. And I think this framework works pretty well for the coronavirus crisis and other spreading diseases. As I discussed in an article in The Atlantic recently, there is an obvious keyhole solution for this problem already being used by countries like South Korea. Adopt a 14-day quarantine. As I discussed in more detail in the Atlantic article, this actually works to limit the spread of disease far better than total exclusion does, and it's less costly and less harmful to both immigrants and natives. The very last point that I will make is that almost all of these objections, while they're usually raised against international migration, they can be raised against domestic migration just as easily. If you think that we can restrict migration to prevent overburdening the welfare state, that also applies to migration from poor states to rich states. If you think that particular cultural or ethnic groups have a right to exclude, that can exist at the state level as well. And if you think that the United States is a club that gets to exclude, then why can't Texas or Virginia also qualify as a club? So my time is coming to an end, but I very much look forward to the questions and discussion. Thank you so much. And I will stop sharing my screen.
Thank you, Ilya, for that interesting presentation on how choices we wouldn't think are political can actually have pretty significant political implications. Our next speaker is Carmel Shachar. She is the executive director of the Petrie-Flom Center for Health, Law, Policy, Biotechnology, and Bioethics at Harvard Law School. Carmel's scholarship focuses on law and health policy, in particular, the regulation of access to care for vulnerable individuals, also healthcare discrimination law and policy, and the use of all payer claims databases in healthcare research. In addition to multiple responsibilities at the Petrie-Flom Center, of which there are many that she's in charge of, Carmel is the co-editor of the center's collaborative health policy blog, Bill of Health. Her presentation is titled Federalism, Public Health, and Pandemics. Carmel.
Hi, everyone, and thank you for having me. It's been a real pleasure. I also love being last to go because I get to hear such interesting talks and hopefully get to incorporate a little bit of what was covered by my esteemed panelists into my talk. I'm going to be considering the role of federalism in public health with a specific focus on pandemics. So I think in many ways, Keith and I have a lot of overlap, including, I suspect, a very nerdy love of medical and public health history. So to walk you through what you can expect from me for the next 20 minutes or so, I'm going to give you a taste of very traditional public health federalism, what you might get in a public health law class if you were maybe a 2L in law school back in the day. Then talk a little bit realistically about the expansion of the federal government's role in public health. We'll consider the interaction of COVID-19 and federalism and think about where to go next. So here I'm going to channel Michelle Mello, who is a fantastic health scholar, and I took her public health law course about 15 years ago, so pre-ACA. And here the very kind of classic in a nutshell is that because of federalism, the federal government is traditionally limited in its role in public health, and that states are expected to take the lead, as Keith discussed, because they have the police power. From the very start, the police power was considered very, very broad, and there were even some admittedly quite old cases that considered that the police power might be beyond the reach of constitutional law. In fact, a court said where the police power is set in motion in its proper sphere, the courts have no jurisdiction to stay the arm of the legislative branch. So we're talking about a system in which the power is really focused at the state level, and that the states have extremely broad leeway. The classic example here are school vaccinations. They were started, I'm sitting in Boston, and so some Boston pride. Now that the Patriots aren't too good, we need to get our pride in somehow. But Boston was the first municipality to require vaccinations in 1827. And obviously a lot of cities and states have followed the way. Applying this to pandemics, because that's really what we care about right now, the most famous example in the 19th century was that the federal government did take the lead in regulating smallpox vaccinations in the Vaccine Act of 1813, but that was quickly repealed in 1822 after there was essentially a bad batch of vaccinations that led to a smallpox outbreak. I think we can use that as a good warning for why it's important to get whatever COVID vaccine is released right the first time. But after that, it really was up to the states to take the lead on vaccinations. Now, in our very quick public health law course, we would be amiss if we did not dive into Jacobson versus Massachusetts, which is from 1905. It's considered the classic public health case, and it is about vaccinations. I want to emphasize how truly old Jacobson is. It's old from a healthcare point of view. I mean, 1905, we're maybe barely out of the leeches kind of approach to medication. But in all seriousness, we are pre the rise of Blue Cross Blue Shield and health insurance. We are pre the rise really of healthcare as the industry that drives the American economy in so many ways. It's just a very different healthcare system. Jacobson is also pre-modern constitutional law in a lot of ways. And I think that now with the pandemic, there's a growing realization that it's all very well and good to wave your hands and say Jacobson, but that because it doesn't incorporate a modern constitutional framework, it's not actually that helpful as precedent. So what does Jacobson do? It's used to defend police power exercises. Post-Jacobson courts have used it to affirm states' authorities to regulate individuals and businesses for public health and safety cases, to limit liberty to achieve common goods, to permit legislatures to delegate broad powers to public health agencies, and to defer the judgment of legislatures and agencies in the exercise of their powers. We've seen a resurgence of courts citing Jacobson. So the Supreme Court did that in South Bay United Pentecostal Church v. Newsom, which was a case about California's order limiting the number of worshipers at in-person religious services. The court had no opinion there, but Chief Justice Roberts, in his concurring opinion, quoted Jacobson, saying, "Our Constitution principally entrusts the safety and the health of the people to the politically accountable officials of the states to guard and protect." Jacobson has also been used in a variety of ways. So the Fifth Circuit applied it in a case looking at a Texas law banning abortion during the pandemic. And the 11th Circuit also looked at Jacobson. In the Fifth Circuit case, they said that Jacobson required courts to limit their review of constitutional rights during a public health emergency. And the 11th Circuit said the opposite, that it was not a blank check for the exercise of governmental power. Jacobson, I think, is really interesting timing because in that same session of the Supreme Court, we also have the very famous case of Lochner, which famously struck down a state regulation limiting hours bakers could work as a violation of the Due Process Clause of the 14th Amendment. Lochner has been critiqued. I think people think of Jacobson fondly and think of Lochner as the equivalent of really ugly Victorian furniture that they would prefer to forget about. But I think that they stand as yin and yang for how much freedom do we want to give states to express their public health attempts? So this ends our Public Health Law 101. And here I have the job of updating you on what has happened since 1905. A lot. So as I mentioned, healthcare has really exploded since 1905. A lot has happened in federalism as well. I won't go too deeply into that because you guys have just had a full day of federalism and pretty much everybody who spoke probably could explain the changes since 1905 better than I can. But I want to emphasize that from 1905 to now, we see really an explosion of the federal government taking a more and more active role in healthcare. And it's things we think of as very basic now, such as food and drug regulations. The predecessor to the Food, Drug, and Cosmetics Act was passed in 1906, so a year after Jacobson. The FDA is now obviously a very active agency. There's the Public Health Services Act, which established federal quarantine powers, relevant for obvious reasons these days. And then there's Medicare and Medicaid, which really put the federal government in the business of healthcare. And here I will say, I think Medicaid is the foremost expression of federalism in healthcare because it's famously a collaboration between the federal government and state governments. It was also fairly slow to be rolled out. So Arizona held out on Medicaid for 18 years, which you can discuss, I think, especially in the context of foot voting. What does that express about the values of the state, and is it serving the people in the state? Medicaid also now has a lot of what we call Medicaid waivers in them, which I think is a really interesting expression of saying, okay, we'll let the states get creative with what they want to do, but only within narrow federal parameters and approval. The other thing I want to highlight since 1905 is that we had an explosion of county and municipality public health departments. So 1911, no county level public health departments and only a few in big cities. By 2000, we see more than 3,000 local health units. This creates a network that's able to deal with pandemics. So for example, if you have a robust Department of Public Health, you probably have contact tracers on hand, which come in really handy when you have an infectious disease pandemic. This trend has been somewhat reversed by states absorbing local departments of health. But as we discuss, okay, where should our response to pandemics fit? That's an important thing to keep in context. So in our very brief romp through health law history, we have to make a stop at the Affordable Care Act, of course. It's now 10 years old, which seems a little crazy to me. I now talk about the ACA to my students and they don't think it's newsworthy at all. It just is. But I think the ACA is a really interesting statute that both uses federalism as a tool to achieve its goals, but is also somewhat limited in its ability to achieve its goals by federalism. So under the ACA, the federal government provided protections for pre-existing conditions, financial assistance for people with certain levels of income to access healthcare, individual and employer mandates. States were asked to oversee insurance markets, run their own marketplaces, define essential health benefits, and manage Medicaid expansion, among other tasks. As the federal government took on an ever greater role in organizing and regulating the American healthcare system, under the ACA tried to do so in partnership with the states. And as I said, sometimes that partnership can hinder policy successes. And here we'll use the example of Medicaid expansion. So the ACA famously wanted to expand Medicaid to really increase the social safety net and make sure that a large population of Americans would have access to healthcare. The Supreme Court famously partially undermined Medicaid expansion by saying that under the spending clause, Congress couldn't condition receipt of all Medicaid funds on the adoption of Medicaid expansion, that it was too coercive. And I will say this was very unexpected. How unexpected? I was a junior associate at my law firm at the time, and I had finagled my way onto the team that was going to write the summary of that case for all of our clients. And they gave me the spending clause analysis because they said, oh, this is a silly side issue. We're not even sure why it came to the Supreme Court. So you're junior, but you should be able to handle this. So because Medicaid expansion became optional, we became a patchwork of approaches to it. So there were some states that adopted it right away. Again, I said Massachusetts. That was a no-brainer. They were already expanding. New York, California felt very similarly. There were some states in which it took them much longer to expand. And we're still seeing this kind of slow trickle. And I think that one thing that's very interesting is the ballot box expansion. in states such as Maine, close to me, as well as Utah. And I think Utah is an interesting case because you see Medicaid expansion on the ballot and it succeeded, and then you see some pushback from legislatures who decide to keep expansion, but take it in a different direction in terms of who's covered, as well as adding work requirements as a condition of eligibility. Here I will say I spent many years working with HIV and hepatitis C patients in communities across the US about ACA implementation, especially in the South. And I think this is where a conversation about voting becomes really interesting, because I spent a lot of time standing in church basements explaining the ACA to people who felt like they were being left behind by the promises of the ACA because their state didn't have expansion. And so they weren't able to get health care. And for whatever reason, they did not feel empowered to say, I live in Texas. If Texas isn't giving me health care, I'm going to move to New York or Michigan or wherever. And there was a lot of anger there among those people saying, I am foremost a citizen of the United States. The federal government promised me these benefits that I am not seeing because of my state. Why is nothing happening? So that was an incredibly interesting moment in time for healthcare coverage. But I think also this kind of inadvertent strong emphasis on federalism and state choices, whether to adopt this federal Medicaid expansion, led to a really interesting public health outcome, because it has left people without coverage. In 2020, there's about 2 million Americans who directly do not have health insurance coverage because of the lack of expansion in their states. We know that expansion states have experienced significant reduction in mortality rates and have been far better equipped than non-expansion states to deal with ongoing crises of opioid overdoses. And I suspect we'll see that they were better prepared to deal with the COVID pandemic. So whether we value saying, okay, it's really important that everybody have some sort of access to healthcare, whether it's through Medicaid or whether it's going through the marketplaces or whether it's being able to purchase it through their employers, or whether we say, we think there's something really important about the diversity of approaches, and we like the fact that that diversity of approaches is really facilitated in this country. I think that's a very clear choice. And I think that's one that we need to be really mindful of, especially with the pandemic. So I promised that I'd talk a little bit about the pandemic. And here I'm going to say that COVID has triggered really significant federalism flashpoints, especially between federal governments and the states. So I know that March feels like so long ago to all of us, but if you can remember back then, there were a lot of fights over procurement of PPE. States felt like they were in competition with each other to source it. States felt like they were in competition with the federal government to source and purchase it. So you heard about governors trying to create secret deals. Again, in Massachusetts, the governor made a deal with the owner of the Patriots to use his plane to fly in PPE and masks and ventilators. That, to me, is probably not federalism at its finest. I think state quarantine decisions are really interesting. States are trying to keep travel to a minimum, but can't shut their borders tightly the way they could if they were separate countries. An interesting flashpoint that is happening really right now over the last couple of weeks is that the Department of Health and Human Services sent a letter critiquing Nevada's decision to mandate that long-term care facilities in the state stop using 2 COVID tests supplied by the federal government. And in fact, Nevada was threatened with swift action, whatever that means. It was left purposely very vague. So the federal government said, we have these rapid tests. We want them to be used in long-term care facilities to stop the spread. And Nevada said, we are not comfortable with these tests. They have too many false positives. We think that is a real problem. It decimates what staff are allowed to serve in these nursing facilities, and we can't have that. And I think really the next big push and pull is going to be over vaccine allocation and requirements, which is basically saying, like, keep space in your mind for that, because that is going to become quite the story. So overall, what tools has federalism given us to combat pandemics? Federalism can help set a floor on public health initiatives. So it can say, here's the minimum that you need to do in order to play. We think this is the basic public health rights of somebody living in this country. But then it can allow some states to take things further. So again, I live in Massachusetts. Massachusetts loves to talk about how it's so advanced in healthcare reform. Whether we get things right or wrong, that's another question. But I think people in Massachusetts would feel disappointed if they had to be held very strictly to just the federal requirements and weren't allowed to go further with their healthcare structures. Federalism can help guide the decision to the appropriate decision makers. So quarantine decisions are really best made at the state or even the local level. And here I'll give the example that the Massachusetts governor has left whether trick-or-treating should be allowed up to each individual town or city. The town of Salem has said, do not come here, because Salem gets always very, very crowded during Halloween. The crowds are the scariest thing about Salem, I can assure you. And they know that even if you just apply to mathematical formulas, a state decision maker might do, they're not taking into account, oh wait, Salem is the Halloween capital of the world. Federalism can allow like-minded states to work together. And we saw this in the pandemic with multi-state collaborations in the Mid-Atlantic, West Coast, and Midwestern states. So states that had a shared history, shared economies, and really felt like we should be working together. And here I will plug a project that I did with the Edmund J. Safra Center for Ethics at Harvard University, where they had a series of reports, and I helped with one called Federalism as an Asset, which talked about how distributed structures are really critical for building resilience, and that's no exception in public health and government. That a state-led and tribally or locally administered approach to a national testing, contact tracing, and supported isolation program can make for easier integration with existing equal protection and civil liberty safeguards and allow more local control, empowerment, participation in ways that actually can advantage vulnerable populations and allow for widespread citizen engagement, which is critical during a pandemic where we all feel in some ways kind of helpless. But I am not a glass half full kind of person. I'm definitely a glass half empty kind of person. So I also want to raise that federalism does present significant challenges to public health, because public health at heart is about organized social cooperation. And it in some ways does best when everybody is doing the same thing and there's few exceptions to its initiatives. Federalism can miss the point with infectious diseases. Outbreaks obviously do not respect state lines. And so if one state is doing really well in controlling the outbreak, but its neighboring states are not, there's only so much it can do to hold the tide back. Federalism can also place entities at odds with each other. So here I'm going to give you the example of Florida, in which Governor DeSantis gave a statewide stay-at-home order on April 1st. He actually then signed another order that seemed to override the restrictions that had been put in place by local government to slow the spread of COVID-19. Then the next day, he issued a statement saying that the later order did the reverse, which confused everybody. And local government officials' reactions to the conflicting orders ranged from, I can't understand for the life of me why he did that, from Hillsborough County Commissioner Chair, to DeSantis is playing politics with the executive order to say he didn't shutter businesses, from the Pinellas County Commissioner, to, I mean, it makes no sense, from the mayor of Tampa. I think federalism can sometimes set states in competition with each other for scarce resources, which is something that you need to avoid, hopefully with stronger leadership at the federal level. And then ultimately, I think we need to think carefully about what policy objectives require the highest levels of cooperation especially in areas of high tension when the various entities involved are unlikely to work well together, and what really does need to be uniform across the country. So what's next? Here's kind of the prescription. I think in order to effectively address the current and future pandemics, we really do need to revisit and modernize Jacobson. I think the good news there is that with all of the quarantines and mask requirements and restrictions, I think there is the potential to get a modern con law update to Jacobson. I think we need to understand how to bridge state and federal tensions more effectively to keep public health responses from becoming as politicized as they have. I think we need to embrace the fact that public health is very much a federal concern these days. As Keith said, it's probably beyond the capacity of states to tackle at this point. And then I think we need to develop plans to avoid a patchwork response to pandemics when we don't think that that patchwork response will serve us well. So hopefully we won't see another pandemic anytime soon. My infectious disease friends do not seem to share that optimism. But I think that this gives us an opportunity to really rethink the interaction of federalism and public health.
Good. Thank you very much for that coverage of public health history and public health law and the intersection between how federalism affects that. Again, those of you who are interested in asking questions, you can submit that on the YouTube chat channel, or you can email it to constitution@uvu.edu. A few questions have come in. I'd like to actually start with one for Professor Whittington, and that is, to what extent have the Supreme Court's decisions limited states' discretion? For example, as the Supreme Court has granted more individual rights and incorporated those rights, limiting state discretion and power, to what extent has that limited what they can do now? And just kind of the example on that, you mentioned that in the 19th century, states were able to restrict immigrant movement into their states. And yet, I believe it was in the Great Depression, a case came out in which they said that the states couldn't do that.
Yeah, I think it's a good question, and as Professor Shachar emphasized, I think it's opportunity in some ways for the court to go back and rethink how to combine some of these earlier cases involving public health with newer evolution of case law. That's true in Jacobson, which emphasizes how we've shifted in terms of thinking about individual rights. The kind of framework that the court used in the early 20th century to deal with the vaccination issue in Jacobson is not the same as how they would think about it now. And likewise, the interstate travel aspect that the court has emphasized more recently of a right of individuals to travel across states doesn't rest easily with these earlier cases that emphasize the ability of states to restrict travel in this context. I think they can be reconciled, but the court has not yet explained how to reconcile them exactly. So, for example, I think that it would be quite credible to reconcile the individual right to travel with the earlier public health justifications for blocking travel by simply emphasizing that this is the kind of compelling governmental interest that justifies some individual restrictions. That's true, I think, likewise in the context of various individual liberties concerns. But when courts, for example, when these local public health officials were first coming online and first becoming very aggressive in the late 19th and early 20th century, they would do just extraordinary things from our perspective about individual rights violations. That it's hard to imagine a current court would be as sympathetic to taking those actions. On the other hand, if you're confronted with the spread of a deadly infectious disease, courts have often been very reluctant. We've seen that with the current pandemic as well. The courts are often very reluctant to second guess how exactly government officials are responding to that.
Thank you. Ilya or Carmel, do you want to respond to that?
Only very briefly. I mean, I think most of what Keith said makes sense, that I think the right to travel, like a lot of constitutional rights, should be viewed as a presumptive right rather than a completely absolute one. I would note that it dates back not just to the 20th century, but even to the 1867 case of Crandall versus Nevada, so it's not that new. At the same time, while I would say that it should be a presumptive rather than an absolute right, I would resist the notion that there should be special deference given to the government just because it's an emergency or a pandemic. I think the history of both pandemics, including this one, and other emergencies, wars, depressions, and so forth, shows that many of the worst abuses of government power happened during those periods. So if there really is strong scientific evidence that the only way to prevent the spread of a deadly disease is to impose severe restrictions on the right to travel, then the government should present that evidence and they should be able to overcome a high burden of proof. If they don't have the goods, and I would suggest actually in the current crisis, often they don't, not always, but often, then their action should be struck down, just as they would in other situations. There's been an interesting role reversal that just a few years ago, conservatives were saying, it's the war on terror. We've got to give lots of deference to government. If they want to lock somebody up in Guantanamo or whatever, courts shouldn't second guess that. And Wibrow said, no, there are important rights that must be protected, even in an emergency situation. Here, there's been sort of a role reversal with Wibrow saying, well, it's public health, so the courts should keep their hands off, whereas conservatives are taking a more, in many cases at least, a more aggressive approach to judicial review. To my mind, the Liberals were right then, and for the most part at least, and the conservatives are right now. Again, for the most part, not obviously in every case.
Thank you.
So I think that the note of caution that Ilya and Keith sound is a wise one to heed. I think, we think of public health as a very positive thing, where it's keeping tuberculosis out of our communities. We don't have to worry about smallpox. These are all great things, but I want to remind people that Buck v. Bell, which was a case about forcible sterilization of women who were perceived as undesirable and that their children were perceived as undesirable, it's the famous 3 generations of imbeciles is enough case, was justified on public health grounds, that these people were a public health nuisance or problem, and therefore they didn't have individual rights to their own reproductive autonomy. And so I think in the case of when COVID-19 is breathing down our necks, it's very easy to justify, okay, states should be able to police their borders very aggressively. And it makes a lot of sense, especially in states where people say, okay, I have been really good in not seeing my family and wearing my mask. And I've heard reports about those people from elsewhere. But, in the beginning of the pandemic, Florida didn't want to let New Yorkers in because New York was the hub of COVID. And then a few months later, the tables turned and New York didn't want to let people from Florida in because now it was perceived as Florida hadn't done enough to curb COVID-19. And so very quickly, what can go from an actual good public health idea that we should stay home and not travel and not bring COVID into communities where it isn't, can become a messy one about control of people in a really inappropriate and harmful way.
Good, thank you. Ilya, your presentation created a number of responses, questions that people raised, and I'm just going to consolidate a few of them together. The question is there a duty of the people to stay where they are to try to improve it rather than to leave? A follow-up with that is what happens to the economies of those places when people choose to leave them rather than stay and help? And I would add to that kind of the question that I think Socrates raises for us, where when we've chosen to stay at a place, do we have a certain responsibility to abide by the laws and even if it unjustly condemns us to death, rather than to flee for our own personal benefit? So those are all kind of wrapped together of what duty do we owe rather than just the freedom to do what we want?
Yeah, so this is a set of questions that I address in some detail in chapter 5 of the book. I didn't include them in the initial presentation because usually people raise objections more from the perspective of the receiving jurisdiction and the sending jurisdiction, but the latter kind of objections are also important. And I have sort of 2 levels of responses to them. My first level is that let's assume the worst, that if you leave, there really is a harm to the economy or perhaps to the social fabric or the like. Still, I don't believe that the government of that country or any country has a right to force you to stay. Each person is owned by themselves. Their labor is not owned by the government of their home country or their home state or city. It's not owned by the other people living there. And therefore, those people are not entitled to force you to stay and work for them if you do not want to, just like we readily recognize in other contexts that forced labor is unjust. Second, at a more empirical level, it is not actually necessarily true that people leaving makes things worse. It often can make things better in several different ways. One is it might incentivize the government to clean up its act and improve their policies. That happens sometimes, doesn't always happen, but there's good historical examples where it occurs. Similarly, in many poor countries that have large diasporas, those large diasporas generate remittance payments where people send money back to their family in the country of origin. In countries like El Salvador, that's like 20 or 30% of GDP. And third, there's also good to have evidence, not in all countries, but in many, where if you have a poor country with a flawed government that has a diaspora in more liberal and more successful societies, that facilitates the spread of liberal democratic ideas back home, which in turn can facilitate reform. Doesn't always happen, but there's evidence that I cite in the book that it has happened, for example, with respect to Central America. So that's evident as well. Finally, the Socrates aspect raises the bigger issue and broader issue of to what extent do we really have a duty to obey the law. I can't do full justice to that in the 30 seconds that I have, or even in my book. I will merely say that how much of a duty you have to obey the law, I think, depends on how just the law is. Like, I reject the view that any real world government has a right to be obeyed and its dictates regardless of their justice and regardless of their validity. Maybe if we had a truly fully consensual government, which was like a private club, then maybe things would be different, but no such thing actually exists. I defend this perspective in some respects in the book in chapter 1. And obviously there's a wide range of other literature on it going back all the way to Socrates. But to make a long story short, I do not in fact agree that Socrates had a duty to let Athens execute him for what were very likely unjust reasons. And if Athens tried to censor his speech and the like, I think he also didn't have a duty to obey that law either, even if the punishment was less severe than execution. Much more can be said about this, and there's a vast literature on the subject, but the questioner asked for my perspective on it, and there it is.
Good, thank you. Carmel, your presentation raised a number of questions about vaccines, and people are interested in, do you think that the vaccines, the states have the power to mandate it? Should the government be able to mandate it, or should people be free to wait until a better vaccine comes out? And do you think that this will be like the flu shot, something that we're going to be getting annually, or is it going to be more varied in how we respond to that?
So I'll start with the piece that I am utterly unqualified to answer, which is the science behind the vaccine. I think right now, nobody quite knows if it's going to work like the flu shot, and you'll have to update it every year. Although I've seen studies that suggest that the particular coronavirus responsible for COVID-19 does not mutate quite as fast as the flu. So we might have longer protection from the COVID vaccine when it does come out. I will say that states already do mandate vaccines. So if you're a healthcare worker in a lot of states, you need to get a certain number of vaccines before you're allowed to walk in the door and work. And that's a group where we feel like that is strongly justified because they're healthcare workers. So they're very frequently exposed, and they're very frequently exposing vulnerable patients. We also require children who want to go to school to get vaccines. And I think we've seen a real pendulum swing from states being more permissive and allowing for parents to say, I have philosophical objections, I'd prefer not to have my child vaccinated, to states saying, no, unless there's a medical reason, you really do need to have your child vaccinated. And this is a great way from a public health perspective to cut down on the infectious diseases floating around the community. Because frankly, if you have seen a child in the last 5 years, you know that children are quite frankly very dirty and very good at passing diseases amongst each other. They're adorable, but from an infectious disease control perspective, they're kind of a nightmare. I think that it's going to be a tightrope, and I think a lot of states will say it's really important to us to get our economy up and running, and we want to get the vaccine out there and dispersed widely. And as long as the FDA says that it meets the standards for safety and effectiveness, it's not acceptable to say, I'll sit this out. I will say as a side note, I think this is why it's so important for the FDA to be really open and transparent, as well as follow all of the procedures so that there isn't a perception that this vaccine is getting rushed out to market for the benefit of any political actors. Because like I said about the smallpox vaccination, once there isn't trust in a vaccine, it's really, really hard to get people to take it. And in the 19th century, when England actually tried to force smallpox vaccinations on everyone, there were riots. So I think most states will probably come up with some groups that are mandatory, such as healthcare workers, perhaps children going back to school. And then there'll be a strong, hopeful education campaign, as well as I think you'll see a lot of employers saying, no, if you're going to come and be in the workplace, we want you to be vaccinated so that you're not a direct threat to the workplace.
Good. Keith or Ilya, do you want to respond to that? Anything?
Just a very brief comment that as a matter of principle, I do not object to mandatory vaccination for deadly contagious diseases. In fact, I think where it works, it's a great thing. I think it's a much lesser imposition on freedom than lockdowns or even than mandatory mask wearing, which you have to do every day. Whereas when you get vaccinated, you get it over with pretty quickly and you live the rest of your life. I do worry that mandatory vaccination for many millions of people in a short period of time, if there are a lot who resist it, it could be a law enforcement nightmare, and it could create some of the kinds of abuses that we've seen in other contexts with law enforcement recently. So I hope people will, and maybe Carmel and some of your colleagues in this area, maybe you should take a look at this. Robert Whittington of the Brookings Institution has proposed paying people to get vaccinated. And I've written a very short piece about this as well. If we pay each person $500 or $1,000 to get vaccinated, that might significantly increase the uptake and lower the resistance. And while it will be a large payment up front, it's much cheaper than even another month or two of this pandemic continuing, both in terms of the direct economic costs and the long-term costs in terms of lives lost and healthcare expenditures and so on. So if this can be done like a mandatory smallpox vaccine or whatever, I'm all for that. But I worry that maybe it would be hard to do it that way. So maybe paying people to get it voluntarily might be an option to consider.
Just to build briefly on Ilya's point there, one feature of this pandemic is it's really emphasized the importance of voluntary cooperation with a lot of these kind of governmental measures. And so it's one thing for the government to simply say, we're locking everybody down or everybody has to get a vaccine. It's quite another thing to actually have the state capacity to enforce that. And frankly, the state does not have the capacity to enforce it in terms of lockdowns. If the lockdowns are going to be real, people have to voluntarily do it. There's an element to which that's true of vaccinations as well. You really need people to voluntarily do it. Otherwise, you're just going to have a long, persistent problem. And so that partially is about then rolling out vaccines people actually can trust, in part because they are relatively safe, in part because the government's relatively transparent and breeds a sense of trust. And it's really crucial the government be trying to build that kind of trust so that people do want to voluntarily participate. But also something like paying people in order to do it would not be unreasonable in this context in order to try to encourage a faster uptake of getting vaccinations done.
Great, thank you. Well, there's other questions and there's lots of questions that I would like to ask, but I think we're down to the end of our time. So thank you very much, all of you, for your great presentations and for helping to advance our understanding of federalism and public health. Thank you.
And thank you on behalf of the center to all of our panelists and to Troy for a fantastic session. It was thoroughly enjoyed by us here in the center and looking at the comments online by our viewing audience. So we do appreciate your participation today. We are now at the end of our first day of this conference. We invite you to rejoin us tomorrow at 9 a.m. Mountain Daylight Time. Our first session tomorrow will be entitled The Economics of Reopening. It will feature Walter Olson, Lauren Heller, and Daniel Mallinson. Until then, please take care.